There is nothing I enjoy more as a healthcare provider than seeing a patient make and maintain tremendous progress with their health. As you might imagine, there's nothing more devastating than watching a patient's health deteriorate when his or her treatment plan is turned upside down. Treatment plans are not universal. One size does not fit all. In many cases, a patient goes through several rounds of trial and error with their physician to find the right treatment that works for them. This process often takes several years. This is the basis of the doctor-patient relationship. Non-medical switching is when a third party, such as an insurer or pharmacy benefit manager, changes the medicine that the patient and physician have agreed upon, not because of medical benefits, but generally to increase profits based on a sales agreement with the drug manufacturer. This practice is widely accepted with generics because they're exact copies of the original drug. But most physicians are less comfortable doing this with biologic medicines. That's because there aren't any generic biologics. There are biosimilars. These are safe, effective drugs in their own right, but they aren't exact copies like generics. They're highly similar to the originals. Also, non-medical switching is done without any consideration of the medical repercussions or reasoning behind the prescriber's selection of the original medication. Non-medical switching by third parties can have unintended negative effects on clinical and economic outcomes. Patients' medication adherence is reduced, leading to more healthcare utilization and higher costs. 69% of U.S. physicians surveyed consider it very important or critical that patients and physicians decide the most suitable biologic to use, the originator or one of the biosimilars. 67% say it's very important or critical that they're able to prevent a substitution they feel is inappropriate. And 71% agree that insurers should reimburse multiple products in a given class, including the originator drug as well as various biosimilars. This kind of competition preserves choice and lowers cost. Third-party substitution of biosimilars is banned throughout nearly all of Europe. Here in the U.S., we only permit it when the biosimilar manufacturer has provided additional data to the FDA showing that a patient who's been switched will have the same results without any additional risks. We call this an interchangeable biosimilar. That assurance makes most physicians, 59%, feel more comfortable with the substitution. U.S. physicians don't object to using biosimilars. 89% would prescribe one to a new patient, and 80% are comfortable switching a patient over to one. What's at stake is who controls the treatment decisions. Will it be the physician and patient making a customized treatment plan based on the patient's history? Or will it be insurance companies and pharmacy benefit managers funneling all patients onto the most profitable one-size-fits-all treatment program? Unfortunately, current law often prioritizes insurance companies as decision makers and puts profits before patients. It breaks my heart to see any patient face this reality.